too many nights. You came by the other day, dropped off a key but wouldn't stay. We couldn't even start a fight. I know it's only been a week, but I can't eat, I'm losing sleep, I'm missing you. On Sunday, I will make a brand new start. On Sunday, I will fix this broken heart.
Hello, everyone. This is Michael Miscoe with Miscoe Health Law for this week's installment of ChiroSecure's Facebook Live presentation. And this week, we're going to talk about new outpatient E&M reporting rules that go into effect January of 2021. For those of you that report evaluation management services for outpatient encounters, new patients 99201 through 99205, established patients 99211 through 215, there is a rather elaborate ad hoc scoring methodology for those services based upon history, examination, medical decision making, and the alternative being where you can bill those evaluation management services on the basis of time, but only where counseling or coordination of care accounts for more than 50% of your face-to-face time with a patient performing evaluation management work. Now, those are the rules for the existing services, and starting 2021, the outpatient E&M services only. So all the inpatient stuff, consults, emergency department, and all of the hospital observation, all of those other kinds of E&M services, they're staying with the same scoring methodology. Only the outpatient E&M services scoring are going to be changed, and the change is rather significant. Going forward, rather than history exam medical decision making, the codes are going to be redescribed in CPT as being based upon either medical decision making only or time only. And what makes that significant is I don't know if it's making things better or making things worse. And the CPT editorial panel has published some rather intricate guidance relative to how you evaluate medical decision making, how you evaluate time, what time counts, and it is going to blur the lines, so to speak, as to what you can bill as levels of E&M. Now, time seems to be the easiest. A couple things you have to remember about time. There's a number of things, in terms of documenting your time. You have to first remember that the code requires, as part of its description, or the new codes will require as part of their description, a medically appropriate history and examination. So it's not like you get to punt entirely on the history and exam. The history and exam helps set the stage for what is considered medically necessary in terms of time spent with a patient, or what conditions we should consider when we're evaluating medical decision making. Now, let's start with time first, because I don't know that it's easier or harder, and I apologize, we only have 10 minutes. This is a 90-minute lecture, but long story short, time is total time. So it includes both face-to-face time and non-face-to-face time. So if you're doing analysis of records prior to the patient encounter, but on the day of the patient encounter, that time counts. Then, of course, there's your medically appropriate history and examination, the time you spend face-to-face with a patient. If you have to coordinate care with other providers, that counts. Things that don't count, things that would normally be done by ancillary staff. And this gets a little tricky because they don't explain, well, what happens if the doctor does it? So let's say in many practices, medical and chiropractic, a staff member takes the history of present illness, or even the patient, does their own history. Well, that time wouldn't count. But what if you're a practice where you do all that stuff personally? Does it count then? Well, they don't tell us that. And hopefully there'll be some more guidance coming out to resolve that little situation. But I think any time you spend performing medically appropriate history and exam, as long as it's not irrational, like you take 2.5 hours to do it, that's probably going to be acceptable. Some other things that don't count: the time you spend interpreting images and writing reports. If you're billing for that time as part of the professional component of, say, an X-ray, then that time doesn't count for E&M purposes. So you only get paid for that time once. If there's time for coordination of care, like team conferences, not like you probably any would ever bill those, but that time doesn't count. Any Otherwise, you need to document your time spent in each activity. So if you spent 15 minutes reviewing the patient's records prior to their visit, let's say in an initial encounter, and the patient sent records ahead of time, and you're reviewing that stuff before you visit with the patient, then you need to record that time. You need to record your face-to-face time and any other non-face-to-face time. If you're a practice that likes to do an initial and then follow up with a report of findings, because that generates too many E&Ms and is likely to subject you to audit, you now have an incentive, if you're billing your evaluation management services on the basis of time, to do that report of findings at the initial visit. So maybe with patient scheduling, you allow more time for initial patient visits to give you time, to go through the history exam stuff that you would normally do, review films, any diagnostics, sit down with a patient, lay out care options, whatever you're going to do, and then document that time accordingly. Now, interestingly enough, completion of the note is also reportable time. And the question has been raised since the publication of these rules. Are docs that are two-finger typers in their EMR system, assuming you're using EMR, do they get paid more because it takes them longer to document their note? And the answer is maybe. Just make sure that, again, you're not taking a coffee break between each keystroke in order to buff out the time. So one other interesting thing about time is that the time hacks for new patient and established patient codes are, understandably different. When we get to the medical decision making, we're going to find that medical decision making is consistent level 2 through 5, regardless of whether it is a new or established patient, which suggests for the same work on a new patient visit, you're going to get paid the same as if it's an established patient visit, which doesn't seem to make sense, especially since new patient E&Ms on the time side, you're doing more work, more time for a new patient visit at one level versus an established visit at another. Talking about medical decision-making, there are still 3 components of medical decision-making: diagnosis, management options, data, and risk. However, they've combined them into one table. And there's a number of ambiguities in terms of condition classification, but in some cases, medical decision-making may get you a higher code, maybe not, but the documentation has to be more precise. Specifically, for each condition that you review in the history and exam, you should load that into your assessment. And I'm not talking things like neck pain and subluxation. I'm talking about subluxation, cervical radiculitis, facet syndromes, all your itises, opathies, and whatever, sprains, strains. And you need to indicate what the status of that condition in terms of, is it self-limited or minor that you're not actually going to treat it? Is it acute uncomplicated? Is it chronic with progression? Because otherwise, it's not going to be clear how that your condition should be counted for purposes of analyzing that first element of medical decision-making. Data is pretty easy to understand when you look at the guidance. The thing is, you get a point for ordering an X-ray, and you also get a point for reviewing one. The question is if you're reviewing one that you ordered and you're reviewing it on the day that you're also billing for the professional component of the X-ray, you get the data points. Unclear on that yet. We'll have to wait for more guidance. And in the absence of guidance, you may have to draft your own policies to figure out how you're going to handle that. But I don't see data driving the train on medical decision-making anyway. Finally, risk. We have the same risk scoring that we had before, except it used to be a big table with 3 columns. Now it's just the 3rd column of the old risk table. And chiropractic care, being conservative measures, is always going to be low risk unless you identify some form of risk factors or comorbidities, what impact they have. They've thrown in some criteria for social determinants of health, the physician, the patient, and without clarifying how they impact the risk or the decision making overall. So we're just about out of time, but I, would love to walk you through in intricate detail, but we don't have the time. But as you look at these new codes, understand they go in place January 1. There's data out on the AMA website explaining the changes. You need to review those so that you're ready to go live and you can figure out what changes you need to make in your documentation relative to your initial visits, progress evaluations, and whatnot, and whether it behooves you to take advantage of time or to look at documentation for medical decision making. And it means you're going to have to push your EMR vendors because they've got to change the structure of your documentation to fit which way you want to go. Now, the path you take isn't unilateral. You don't have to always go with time or always go with medical decision making. You can go back and forth as the case dictates, but you need to be able to document in your EMR record, hopefully without too much extra typing. If you're going time, what you spent time on specifically. This category of things, this is what I did, and it was this many minutes, and then total it up at the end. Or medical decision making, where condition classifications, the status, is it improving, is it exacerbated, and all of that stuff become critical to being able to evaluate medical decision making. Hopefully this gets you interested in doing some analysis and research before these changes take place, because you don't want to get blindsided coding under the old system when the codes have changed in CPT. So this is a rather significant change, a little bit of a heads up. Try and stay ahead of the curve, and hopefully we'll have some more time to talk about specifics, but don't be frustrated when you read the rules. There's some things you're not going to understand, and only because I don't understand them either, so don't feel bad, and I get paid to evaluate this stuff. But hopefully as we illustrate those ambiguities to CPT, we'll see what they do, and then we'll have to wait and see what CMS does to see if they deal with time and medical decision making the same way CPT does. So a lot left to figure out before the end of the year. Stay tuned, and as updates come along, we'll pass them your way. But for now, start looking at these changes and figuring out how you're going to deal with your documentation so that you can appropriately get credit for the E&M work you're doing. That's all we have time for today. Hope that was informative, and we'll see you next time.